And what are affirming services? What does that look like in your particular practice, in your agency, in your organization? And we're going to talk about advocacy and outreach. So if you have things that you want to be providing, are there barriers there? Are there ways to overcome that? And how can you go a step further than just being a welcoming organization to really doing some outreach and advocacy in your area of work if you see that that's a need?
I just also want to toss out that there are probably varying levels of knowledge and understanding about this population. So some of what we present might be, really basic for some of you, and for others it might be the first time you're hearing it. And so, just bear with us. Hopefully everybody will get something out of this.
Well, and we want it to be a safe place too. So there's no questions that aren't okay to ask. This is the place to ask them. It's a safe place to do that. We're going to do our very best to answer questions. And if you haven't already seen the resources that we handed out for this or created for this, they're pretty extensive. So if we can't get it answered for you today, we can certainly point you in the right direction of where to get that answer, or to just learn a little more or delve a little more deeply.
So one of the important things to remember in working with, and I'm going to say these populations because there are some unique issues for each, is that for the older generation, there's a number of folks whose connections with family of origin may have been broken or very tenuous. That thankfully is changing as more and more parents are becoming accepting, and siblings are becoming accepting of younger generations. But for a lot of older gay, lesbian, or trans folks, they may have lost a lot of family along the way. And so there may be some isolation. They may be less likely to have kids or grandchildren or other nuclear family, although again, with the lesbian baby boom, and actually it's also amongst gay men, a lot more same-sex couples are having kids of their own along the way, and then later on grandchildren. And a study showed that the LGBT folks are more likely to be caring for a friend or family member than that amongst the heterosexual community.
One thing I might point out there too is, in my work and in the practice that I've done, and just in general, there's really a pretty big difference even between the seniors that we think of in maybe their 50s or 60s, or even to their 70s, in regard to their level of family support and those kinds of things. Folks that identify as GLBT, who are kind of the old, what we think of as the old olds in their 80s and maybe 90s, have had very, very different experiences than the boomers. So they're likely even more isolated, more closeted, more concerned about these issues, and aren't going to be as comfortable with talking to you about these things. So there are some real barriers to successful aging for these. No, you're fine. For these populations. Stigma, as you can imagine, certainly unequal treatment under laws and programs. We're going to be talking about different, we're going to talk about Social Security benefits today. We're going to talk about spousal impoverishment rules for Medicaid eligibility. So there are definitely some different things that create barriers, and how they impede. So changes in financial security over the course of a lifetime really impact. Poor health and access to health care. We're going to talk about specifically what those two things look like and the why behind that. And reduced community support, which we've already addressed a little bit.
Mm-hmm. So let's just talk about what the experience is of a lot of the seniors that we might be working with. The majority of those that are 65 and over have experienced very distinct instances of discrimination. They grew up at a time where the level of social stigma was much more intense than it is now, and it still is really rough for a lot of LGBT people, even kids in schools. The population is one of the most targeted for bullying still today, even though attitudes are changing. And there's still out and out inequalities in terms of legal protections for relationships, lack of protections for employment, etc. But it was even more intense for this older generation as they were growing up and coming of age. The effects of prejudice and the attitudes of seeing gay people as criminals, until 2002, sodomy laws were still considered constitutional, and so you were breaking the law by being physically intimate, expressing your love with the person that you love if you happen to be in a same-sex couple. Mentally ill, it wasn't until 1973 that homosexuality was taken out of the DSM, and gender identity is still in the DSM as a mental disorder. They've changed the name, now it's gender dysphoria as opposed to gender identity disorder. And that's very controversial, whether to have that in the DSM or should it be a medical disorder. So, to give an example, in 1969, the Stonewall Inn in Greenwich, New York, there was a riot at the Stonewall Inn when there was a police raid on the bar. It was a gay bar, and the patrons revolted, and there were like 3 days of riots, and suddenly gay rights was in the news. Before that, there were almost no organizations working for equality for this population. 5 years after that, there were over 800, and there's huge growth. It was a pivotal moment. But in terms of expectations and where people have come from, in 1969, I was 4 years old, and someone who's 65 was like 20-ish, and they have experienced, it was routine for police to come in and raid gay bars just because, and you would be arrested for public indecency, all kinds of charges, and they would publish your name in the paper, and then you would lose your job, you would be outed to the community, and that was routine. Now that I'm grown up, I was 4 years old back then, I have gone to lots of gay bars because I identify as a lesbian. I've never once worried about that, about being arrested by going to a bar. So, a completely different world.
So some of this fear, then, you can understand might lead to a lack of disclosure when interacting with agencies or service providers. Folks do tend to omit important health details, even to their physicians. So they might not disclose, if they have an STD, they might have an open discussion about sexual activity, but they might not mention the fact that it was heterosexual or homosexual, or, they just don't disclose important details to folks. To social service agencies about relationships and support. One of the examples I'll share with you a little bit is I worked in hospice for a long time, and I had a very elderly couple, and these gentlemen had been together for many, many years. They had a beautiful relationship, but it took me a long time I suspected and I wanted to support them in that relationship, and with the proper grief support, but they identified as cousins because they were very concerned about their position. They had experienced discrimination. They changed some communities a few times, and they were very worried they wanted hospice and they wanted it at home because they were very worried about entering the healthcare system and how that would be viewed. And so, even disclosing to a provider that is in that intimate of a setting in their home, we had to really talk about, eventually it just sort of came out. It never was a big revelation. They just finally kind of let me in. But then that helped me to then have a conversation with our providers and our nurses and our staff so we could be respectful of that relationship. So social service agencies, health agencies, folks don't necessarily always disclose, and that requires all the more need then on our behalf to make sure that we're demonstrating a safe space and that it's really okay for people to talk with us.
One of the things we'll talk about a little later in the second half is when we say creating a safe space, that's not only with staff, but it's also with interactions with other clients and the agency, support groups, grief support groups. If you've just lost your partner of 50 years, or in some cases your legal spouse of 50 years, and you're going to the support group, but you don't feel safe being open about the nature of that relationship, that kind of dampens your ability to benefit from that space and that group. So creating that safe space across the board. So we want to show you just a clip of a trailer for this really wonderful film called Gen Silent. If you have a chance to bring that to your agency, you can order it through a website. It's a really wonderful documentary. And so let me pull this up. Oh. Here we go.
A lot of people believe that you just live happily ever after, and that's just simple.
People like ourselves, older, are hiding in nursing homes or whatever because they are scared to death.
It's incredibly common to go back into the closet again.
You just know when they don't want you there.
We've heard about homemakers going in, taking out a Bible and having the elder pray and asking for forgiveness.
And to be cured. It's not too late for you to be cured of this. They go back in the closet. She might mistreat me or abuse me.
They're so afraid of it, they are resisting any kind of medical attention.
That person was in their mid-20s during the McCarthy era.
The closet was the norm. They could lose their job, they could lose, families.
We were sick. We were sick. We were
people.
considered sick.
People were involuntarily hospitalized in psychiatric facilities.
Even electroshock.
The degradation of these people is so complete that their sex satisfaction comes only in being tortured themselves.
I was on the route to the nut farm.
So there's a real distrust of mainstream institutions.
I would never put myself in danger.
He became much more fearful of people knowing that he was gay.
You're not leaving now.
Not right now.
LGBT elders are more likely than the general population to age alone because many gay elders never had children, have not had great relationships with their families of origin. There would be a higher degree of sort of alienation and isolation.
My family was the reason I existed, and I lost them all. If they ever choose to catch up before I die, I welcome them.
LGBT aging issues are an epidemic.
There's a small and growing group of us.
We're trying to go into the existing network so they become more inclusive. One of the most common lines we get is like, we don't have any gay elders here.
If I wasn't the only person responsible for Alexander, I would have ended my life.
This is our life.
Good to see ya! Hi! I'll be there in a few years.
I built a stairway to paradise.
Oh, with a new step
Every day. We have a whole generation of people who don't know who we are. That's really sad, because you're missing out on a lot. We know a lot. We did a lot for you. You wouldn't be here if it weren't for us.
Keep it on strongly. Too bad it doesn't have an open casket.
Well, there'll be no open casket. There won't be anything, right?
If we are saying come out and be filled with pride, it's our responsibility to make sure that continues right through their last day.
This really is a wonderful documentary, and it's done in a very approachable way. And if you are looking for something to help provide an in-service or start a conversation or bridge a gap in your agency or community, I would recommend just getting this, taking a look at it, and it's excellent.
Yeah. Okay, so we're going to talk some about some of the health disparities that we see in the LGBT population, some of the reasons for those health disparities. And, really what we're talking about is a lifetime of discrimination, multiple events, large and small, and attitudes. And if you were in any of the earlier sessions with Dr. G talking about the effects of stress on the body, this plays out to a huge extent in the LGBT population as people are experiencing, financial inequalities, employment inequalities, and negative attitudes and rejections. And every time you come out, it's a risk. So folks end up being at risk of a higher level of social isolation, depression and anxiety. We'll talk a little more specifically about that. Poverty, chronic illness, delayed care seeking, especially amongst the transgender community still today, because so many people encounter really negative responses from doctors and nurses in care settings. Poor nutrition, premature mortality. Oops.
So stigma and marginalization obviously affect health, and this morning kind of underscored that better. Right? We don't need to cover too much of that actually, but we do want you to know kind of what those risks do. So a lifetime of this kind of fear and concern and heightened anxiety really does play out. We definitely have increased rates of mental health disorders. Substance abuse, because if you're really stressed and you're really concerned, or you have had, I thought the comment that she made this morning about trauma as a child, your increased risk of having substance abuse, and if you were in a family that was not accepting and that was a turbulent relationship growing up, you can see how that might play out. And higher incidence of obesity and physical inactivity, all of those kind of stressors that we talked about in this morning's keynote really come to play there. Eightfold increased rates of attempted suicide, of course also tied to depression, right? So pretty substantial, and a threefold increase in successful suicides, because often we know that people, when they commit suicide, their first attempt is not successful. So if there's an eightfold increase, people are making also more attempts more often and eventually then do succeed. Higher incidence of hypertension and cardiovascular disease, all again, stressors that we talked about this morning that affect our overall health and well-being. Bulimia and anorexia, that real self-hatred or real concern about how you're seen by the world can certainly inform those illnesses. And a higher prevalence of risky sexual behavior, because you're not necessarily, our seniors had to have their relationships really behind closed doors, as it were, and often had to kind of sneak off and hide their relationships.
Well, and often if your self-esteem is suffering, we know across the board, whatever your sexual orientation or gender identity, low self-esteem is associated with riskier sexual behavior, not taking precautions.
Putting yourself in unsafe situations.
Increased alcohol and drug abuse increases those risks as well.
Sure.
There was a study that happened before the 2004 presidential election, funded by the NIH. Over 30,000 people were surveyed across the nation, looking at incidents of depression, substance abuse, generalized anxiety disorders. And then these researchers actually went back, did the same survey again after that election. And in that election, 13 states passed constitutional amendments to ban same-sex marriage. And what they found is that in just those 13 states, they saw a 38% increase just in the GLBT population, 38% increase in depression, 42% in alcohol abuse, and a 248% increase in generalized anxiety disorders. Just in those 13 states, there was a slighter increase outside of those 13 states among the LGBT communities. And amongst the straight communities in those states, there was no increase. So it's pretty suggestive of the effects of having gone through a campaign that year where, you know, negative things were said about same-sex relationships, that people felt under attack by their own, you know, elected officials and neighbors, many of whom voted for these amendments. Took a huge toll on people. And then there's another study, and Mueller has done a lot of work on the public health effects of stigma and discrimination for the LGBT community. He found recently that they went in and looked and did an assessment of communities to get at how homophobic or how accepting and affirming these communities are, and they came up with these rating numbers based on a number of different factors. And then they looked at mortality rates and average lifespan of the LGBT community living in those towns, and found that if you lived in a homophobic community, you died on average 12 years earlier than if you lived in the most accepting communities.
So, neglect, harassment, and discrimination. A large number, 8.3% is significant, of LGBT adults surveyed report being neglected by a caregiver because of their orientation or identity, and those reports are based on both institutional care and in-home agency care and home care, period. 8%, almost 9% reported financial exploitation, and 39% of transgender people face some type of sexual harassment or discrimination when seeking routine health care. And I'm going to ask Jean to talk a little bit more about that. And this financial exploitation thing, I don't know if it was today or yesterday, I think it was yesterday, there was a seminar on elder abuse. So that financial exploitation, I don't know about you all, but I'm seeing more and more of that in my practice, and it's something that I have to pay attention to. I certainly work with people with Alzheimer's, which places them more at risk, most definitely. But in general, this is really a problem. And so if someone has fewer supports, is less compromised, doesn't have as many strong supports in their system or as many trusted people, it does place them in a more vulnerable situation to be taken advantage of and be exploited.
This number, the 39%, that's huge. You know, that's over a third of transgender people, and some studies have that number higher. Depends on geographically where you're at and what the attitudes are. There was a case a few years ago, a hospital in central Indiana, where a transgender woman and her female partner went in. The transgender woman was she was vomiting blood. I think she had like an ulcer in her stomach that was bleeding, and that's a life-threatening situation. And she was treated so atrociously in that emergency room, and a doctor came in and said, "I don't treat transgender people. I don't know about that." Nurses were referring to this patient as it, and talking to the partner like, "Why are you with it?" And really offensive stuff. They finally left and drove to near Indianapolis to get medical treatment. Now, the good thing is that after that story became more publicized, some advocacy groups went in, worked with the hospital administration, and that hospital now, they put all their staff through training, and they actually are doing a very good job of serving the trans community at this point. So, but that person could have died. And I know transgender people that do not go to the doctor specifically because they've had bad experiences before. Just, somebody breaks their arm. I don't really know how to treat people if you're trans. People who, I know of a trans guy, there was a movie called Southern Comfort, where this transgender man died of uterine cancer because he could not find a doctor that would treat him. Because, I don't know.
So it's not an uncommon call. I think it's partly because Jean certainly gets these calls because she's known for her work, but because I am known in our community as providing affirming services, I kind of get cold calls once in a while from folks. And I don't often know how they got my number or why they were referred, but they'll say, hey, I'm looking for a physician for myself or my partner. I'm transgendered. I've got a health issue. I haven't had good experiences with my physicians. I'm trying to figure out who might be an affirming provider who I can see, and could you help me with that? And gosh, what an awkward, difficult, what guts it takes to make that call, for starters, and how sad that there's a need for that. But that's been a real surprise to me, and it's not uncommon for that conversation to come up.
So just one more layer of this. So if you happen to be gay or lesbian or bisexual in a same-sex relationship, let's say, or transgender, and you need home health care, how do you know that your provider, the people that are actually going to come in and bathe you are not going to be making negative comments or try to, save you or something? You don't need that when you're already dealing. Getting older is not, it's not an easy thing. You've got a lot of challenges to face. And when you add this in, it just is one more unnecessary level of challenge.
How many of you are from area agencies on aging? You provide a lot of you. Okay, so and I did that too. It was actually one of my favorite jobs. Hardest in some ways, most wonderful in others. You can be the most affirming provider and be really wonderful to your client. But how do you know that the home health agency or the service provider or the home delivered meal provider or whoever you're contracting services for to go into that home is also going to provide that same kind of support and service? So you're in a really unique situation to be both an advocate for your client and a community educator and kind of a safety valve for the family that you're working with, which makes you a change agent in your agency too. So this might be a place to start by saying, hey, how do we really know that if we're going to say we're providing services? And we'll talk about that a little bit more in the second half.
So there are federally over 1,100 rights and benefits conferred by marriage. Now,
which means if you get married, you don't have to sign up for them. You just get them.
If your marriage is recognized. Now, y'all are probably very aware of the changing landscape around marriage. Here in Indiana, just back in January, we kind of headed off a constitutional amendment that would have written, a very narrow definition of marriage into the Constitution and banned anything similar to it. And then we had a court decision, a federal court decision, that overturned Indiana's marriage ban that's in the law on the legal books. But that decision is stayed. So, for example, on June 26th, during the 3 days that marriage was legal, my partner of almost 17 years and I went down to the courthouse and got legally married. But it has no impact on how the state of Indiana sees us right now because that decision is on stay. So I'm still having to buy my own health insurance and all of that because I can't be insured under Jenny. So, but federally, they will recognize our marriage. Different parts of the government will recognize our marriage. It all comes down to place of celebration versus place of residence. And Social Security for a long time has been, they determine whether you're married based on where you live. And so in Indiana, they don't recognize our marriage, even though they performed it. They are gradually converting over to place of celebration. If your marriage was legal when it was performed in another state or whatever, but your state of residence doesn't recognize it, they're gradually shifting over, and there are more and more benefits that are coming with recognizing place of celebration. So it's a legal hodgepodge right now. I talk to lawyers, and they're not exactly sure what the status is for a lot of these benefits.
Which means when you're trying to help people qualify for benefits and services, pretty darn confusing stuff. And Social Security on a good day, challenging. In this situation, really challenging. And I will say though, to their, both to my happiness and to my chagrin, so when you pull up the Social Security website, there is a section for same-sex couples, and it has one of those great big yellow like exclamation points that's like, wait a minute, just cautionary, here's, and it talks about that place of residence, place of celebration, and that they're in process. And, just think with me for a moment about how long it might take the Social Security Administration to work through a process of change. It's overwhelming. So as Jean and I were digging in, we just say to you, it's literally changing on a weekly basis right now.
Right now, there are 19 states that...
this week, today.
Today, it could change tomorrow. 19 states in which same-sex couples, 19 states in the District of Columbia, where same-sex couples can legally go down to the courthouse and get married and have full benefits in their state and recognized by the federal government. There are 14 states where there have been court cases and a decision has been made that overturned the existing marriage bans, but all of those decisions are stayed, which means they can't go into effect until it's heard by an appeals court. In Indiana, the Indiana and Wisconsin cases are going to be heard on, I think it's the 26th of this month, at the appeals court level. But even once you get a decision there, let's say they uphold the lower court's decision to overturn the marriage ban, there will probably be another stay issued. And so ultimately this has to get to the Supreme Court, and they maybe, hopefully, will settle it across the nation. That could be sometime next year or the year after. So there are 14 states in limbo. There are court cases, challenges to marriage bans in every state of the nation. They're just working their way through the courts. So it's just a hodgepodge. And if you happen to be a same-sex couple and you're legally married, and you go on vacation and go on a road trip, be aware that as you drive from one state where your marriage is recognized, if you get in a car wreck, you're okay. Everybody will recognize your marriage, for making medical, but when you cross the state line and they don't recognize it, then you don't have any legal rights unless you're carrying some papers for power of attorney and such, and then you go to the next state and then you're recognized. So your marriage will appear and disappear depending on what state you're in. So, and, if you happen to be an older couple and you can't leave the state because of transportation issues or health issues, and you can't go next door to Illinois to get legally married, you can't access those federal benefits that are accessible because you can't get out of state to get married.
So Social Security benefits. So prior to the overturn of the Defense of Marriage Act, $124 million there were $124 million in unaccessed benefits. So that place of residence and place of celebration we talked about, and obviously there are a lot of efforts happening right now. But think of some of the clients that you work with and the poverty rates that they're dealing with, and what this amount of money divided over some of those folks would really do. It would make a big difference for a lot of folks, wouldn't it?
So we're talking about survivor benefits. If somebody, didn't earn that much during their career, but their partner did, there are things in Social Security policy that will help bring that other partner's benefits up to a reasonable level. And then when the higher earning partner dies, they get survivor benefits. So you guys can't read this. If you go to the source, there's some really good information. The outcome is huge disparity, 120% of the poverty level for a surviving heterosexual spouse, 29% of the poverty level, and you probably can't afford to keep your house if you're in a same-sex relationship that is not recognized.
The other part of that I will point out is that in terms of rates of poverty, heterosexual Caucasian couples turn out to be in the highest, that percent of poverty category, and as you work your way down, lesbian couples are much closer to the bottom of that, and African American lesbian couples are even at the bottom. So it follows both gender and heterosexual
and racial levels.
Yeah.
So it's layer upon layer upon layer of economic disparities.
The more minority groups you're in, the closer to the bottom. you fall. So spousal impoverishment and Medicaid. We are not going to spend a lot of time on that. That is a whole different seminar. But are many of you familiar with that concept? Yes, that's what, largely within the norms that we work. So just know that CMS allows protections, similar protections for same-sex couples. However, at this point, most states do not offer those. So even though the federal government says it's okay to do that, states, just like this marriage equality issue, that's an issue that's administered at the state level.
Yeah, and states have the option of not recognizing same-sex couples for the spousal impoverishment protections. So the way it really breaks down is, you know what, I think we can skip that. Yeah. So huge economic disparities.
So poverty rates of seniors, it breaks down really like this. Compared to their heterosexual counterparts, straight couples are at 4.6% of poverty, lesbian couples are at 9.1%. We talked about this a little bit, but that's a pretty big, that's almost double. It's significant.
Okay, so some terms and language. Make sure that we all understand the basics of what we're talking about between sexual orientation and gender identity. A lot of folks view those as two different aspects of identity. This may be really basic for you, but sexual orientation is the direction of your affections based on gender. So your own gender and the gender of the other person. And so typically that falls out as heterosexual, homosexual, and normally homosexual is just like the direction of affection, but we're talking gay men, lesbians, or bisexual. And then there are a lot of other people that identify as pansexual, bisexual lesbian. I mean, there's all kinds of different ways that people identify. And so in general, it's good to ask how people think of themselves.
And will you touch just for a couple seconds on pansexual for folks?
Pansexual is my attraction is to the person. It doesn't matter their gender or their identities. They may identify as bigendered or not identify as a gender. It doesn't matter. I'm attracted to the person. And there are more terms evolving every day. So, I'm going to back up. Term queer. Queer could be a very offensive term to some older gay people, and is a very affirming term to a few older gay people, and probably more younger gay people. So be careful with that term. It's been used as an insult for a lot of years, and then the community kind of reclaimed that term and wear it proudly. But not everybody does. Some people will be offended by it.
The rule I kind of use with that is if people identify themselves in that way, I'm respectful of that, but I choose not to use that term because I'm never really sure how well that's going to be received, and I feel like that's not appropriate. It does not consistently display respect depending on who I'm speaking to, so it's just better for me as a heterosexual service provider to stay away from that because I don't want to inadvertently offend somebody.
So, sexual orientation, so you're attracted to based on gender. Gender identity is how you identify yourself in terms of gender, regardless of what your biology might say, regardless of what your genes might say. It's, how do you identify as male or female, or is it that clear for you? For some people, it's not. And it's not that they're confused, it's that their sense of gender is more complex than just male or female. So identity labels can include, transgender. Transgender can be offensive to some people and claimed by other people. I know a transsexual woman that her head will explode if somebody calls her transgender because of what that means to her and what transsexual means to her. The shorthand for some people, they're comfortable with, I'm a trans man. Some people say, I'm a guy. And they don't even, they don't want to deal with the trans part because that's not now a part of their identity. They are who they are. Gender queer is really comfortable for some people, not for others. Bigendered, that's generally folks that maybe identify with both genders, and some days they feel a little more male and may present a little more male, and other times they may feel a little more female and present more female, and claim that term. You heard of Two-Spirit? That's a term that is more, comes out of the Native American communities. And again, it's not across the board with all tribes. And there are some tribes that in modern day are more affirming of the idea of Two-Spirit and others that are not. But in a lot of tribes, before they were really influenced by white Anglo-Saxon cultures, they considered gender to be more than just two. There was, Two-Spirit people who might be male-bodied but more female in their spirit. And a lot of those folks their gender identity was appreciated and valued, and they held positions of respect within the tribe. And so, and just from an early age, that would be affirmed for them. It's changed a lot with a lot more influence from, the invading European cultures. So,
at this point, before we move forward, I want to take an opportunity to just give people a chance to ask questions, to talk. I'm really very interested in if there's anything specific that you hope to get out of the presentation, because this would give us a chance to kind of know that and tweak the second half to make sure that we kind of have what you want. We're happy to plunge on through, but it's a good time. We have some time. It's a good time to do some discussion.
I'm also really interested in hearing what your experiences have been in working with gay, lesbian, bisexual, or transgender people in your practice settings, or what's your sense of what's happening in the community, especially amongst older adults. Have you had any experiences?
Let's see. No.
I work in long-term care setting, and we are seeing an increase in
Okay.
openly gay individuals.
Yeah.
When you showed the video and that we don't have any gay elders here, that triggered because I'm sure that I've served gay individuals before
Sure.
and didn't realize it. And in fact,
We all have.
and have a gentleman now who's in a committed long-term relationship. We've had him 3 times. He's bounced in and out. He's been out there long-term. But it was his 3rd visit before we found out that the person who cared about him was actually his partner, because he didn't feel safe enough to share that with us.
So he needed to be in your facility for a while to get to know your staff, and maybe those rehab visits or short stints were almost ways for him to decide, is this a safe place for me, or am I going to go someplace for my next rehab visit?
And
Yeah.
I do worry about, for folks who are transgender, transsexual, with talking about the physical, providing the physical hands-on care, and how
Right.
we have, tend to have floor staff that is not well educated, that are
Sure.
don't know how to process and they're gonna say slang words, they're going to be insensitive,
Sure.
and how do we make that a culture that we're not gonna tolerate? We don't want that to happen to any of our patients,
Absolutely.
but it's going to be something that's gossiped about in the break room where it shouldn't be. So how
That's
do
a
you stop
really
that
good-
and redirect those conversations and make it okay for everybody?
Well, and a very basic thing to check in your agency or your facility is in their non-discrimination policy, is gender identity and sexual orientation included? I mean, that sends a huge message, and most people in the community, in the GLBT community, will check that. They'll go to your website.
Before they ever come to see you.
Yeah, and if it's not in there, that says at least, this place has at least a blind spot, if they're not homophobic or transphobic. And they probably aren't doing much training around it. So I don't know, maybe it's okay, but I don't know.
Well,
I'm
we
not
have
sure.
no training mechanisms at this point to address,
Right.
Any of these concerns or issues. So that's
So
something we need to look at.
one of the things, some of the things that we're going to talk about then in that second half, and we may even go ahead and dip into a few of those, depending on our time, are talking about some very super simple, kind of low-hanging fruit that can create change in your infrastructure without like a big in-service. And words mean a lot, language means a lot. So even if you go back and say, hey, I went to this great training and I didn't know some stuff and I learned some stuff, so I'm just going to do this instead of that. or, you know, that in itself is kind of a big thing. So don't underestimate the power of you as an agent of change in your organization. It doesn't mean you have to go back and bang the drum. That may not even be job safe for you to do, right? And so that's a good starting point. And we're going to offer you some resources and some materials to do that. I will tell you, I had a bachelor's in social work practicum student a number of years ago who happened to identify as a lesbian, and I don't even really think her practicum placement knew that. She wasn't, you know, very forward about it in that setting. She worked in a long-term care setting, and she came to me and she said, I am absolutely convinced that this couple, that these two roommates that have been best friends for over 50 years are a couple, and that we're not paying attention to that, and I'm worried one of them's going to die, and we're not going to give them the right support, and this is going to be not good. You know, what can I do? And I said, well, I don't know. What do you think? What can you do? And she did the stuff that Jean said. She checked their non-discrimination policy. She kind of worked through what is the policy and procedure manuals, what trainings are people getting, what is just the onboarding. Forget the end service. What does the onboarding employee orientation stuff look like? And I said, well, I think you've got a project, you know, for your senior practicum. And so she called Jean, and we did a review of just basic forms and some things like that. She put together an end service on not specifically on LGBTQ issues, but on sexuality in the older adult. Because she thought, oh, okay, I can provide that training. She had to go to the administrator and go over the whole outline and really sell it. And he was like, I don't know about this. And she's like, because we don't have anyone in this facility having sex. And he's like, well, I didn't say that. She really had to advocate. And I mean, as a 21-year-old coming in from the outside with as a student, that was really scary for her. It also made her the perfect person because she was a student. Right? So she could come in and kind of shake it up a little bit. And she planned 2 in-services, but they didn't make them mandatory, and they were both going to be for different shifts, right? So they could catch different shifts. She called me after the first one, and she was in the social work office, like cowered in a corner, crying, going, nobody came. I don't even want to leave the office. Like, I think people are just mad at me. Like, I heard some nurses talking about how stupid this was. I mean, she was just leveled. And I said, okay, well, let's figure it out. What are you going to do? And she knew there were a few people in the agency who would be behind that training. And so she got herself out from behind the desk. She went and found those people and said, I'm going to do another one at such and such time. Can you be there? Will you be there? She got a few people to commit. And they were well-respected folks in their departments. And I said, I'm showing up, I'll come. It might just be you and me, I'm coming. And it was just in the little tiny social work office. They didn't even give her a room to do it in. And I want you to know that office was crammed, and people were really receptive, and they started handing handouts out to some of the other staff. It was a little tiny thing, and it made a big difference and just started some change. So it doesn't have to be big.
Yeah, you got to start somewhere.
Yeah. What else? Any other thoughts or experiences or questions that you want to make sure we answer, or resources? Yeah.
Maybe in the next session, if you get a chance, maybe talk about urban versus rural.
Yes.
I work in a very rural county where a cow will stop the entire county. And things are different there than they are, say, in
and we will, absolutely, that's great. And we'll talk about our area agency on aging too, because it serves Monroe and Owen County, and Monroe is more urban, and Indiana University, and more, diverse, obviously. But Owen County is not. Owen County is just what you said, very rural. So we will definitely talk about that. Thank you. Anything else for this? And we're done here. Holly, is it a quarter after?
Yeah.
Okay. So,
yeah, if anybody has any questions, you want to come up, talk to us on break, or comments, or ideas, let us know.
The only reason we're kind of stopping here is because this takes us off in another direction. And if there's people who just are coming on the second half to kind of get this, we don't want to be 3 steps ahead of them when they get here. So, all right. Thank you.
So we'll see you back in, 15?
15 minutes.